This is the Shelbourne Center podcast. This is Dr. Benner, and I'm here with Scot Bauman tonight to discuss another great topic, some more content for those of you out there who want to learn more about knees. Last week, we talked about early predictors of return to sport after ACL reconstruction, and that was a really good topic, talking about some physical therapy parameters and some other variables that are at play as athletes get back from ACL reconstruction. I would encourage you to go check that one out. We have a lot of great content. We have almost 40 episodes up now. If you'd like to go back and learn from all of those, make sure you follow to not miss any of our subsequent content. And if you'd like to leave us a 5-star review and some comments for those that come behind you, we'd appreciate that as well. You can find us on social media, on our Facebook and YouTube pages, the Shelbourne Center Podcast. You can find us on Twitter and Instagram at the SKC Podcast. And you can also email us at the skcpodcast@gmail.com.
And tonight's going to be another good episode. We're talking about arthrofibrosis following ACL reconstruction. And I think this is going to be a good discussion. We're going to start talking about just generally what arthrofibrosis is, what causes it, those types of things. And I think it's going to be important for many different clinicians, not only the surgeons out there that are operating on this condition, but the physical therapists that are seeing these patients both before and after surgery to see what type of results we're getting with this type of surgery in this condition. So, and then we're eventually going to get into a project that we worked on, and it actually is going to be at the AOSSM summer meeting this July in Denver, Colorado. And those that worked on that were myself and Dr. Benner, along with Bill Claussen, physical therapist in our office, and Dr. Shelbourne. So before we get to that study, Dr. Benner, I just wanted to have a brief conversation here to start, just to give some more details on arthrofibrosis, specifically following anterior cruciate ligament reconstruction in general. So can you speak to how often you see this, what it presents like in the early time point after surgery, and maybe your thoughts on what types of things causes this?
Well, I'm fortunate now that I've been able to learn from Dr. Shelbourne's legacy in treating this condition, and ultimately really focusing on not treating this condition, but how do we avoid this condition. So luckily, I see this very little in my own practice because we very rarely have stiffness after ACL surgery, but we do see a fair amount of revision surgeries or complications from people who've had surgery elsewhere that have come to see us. And because of that, I feel like this is something that we're in a unique position to really make some comments on, as Dr. Shelbourne is an internationally known expert in this condition. You know, I feel like I've been able to learn a lot from Dr. Shelbourne as well as his techniques, and been able to apply them myself to the point where I feel like we can get equivalent results regardless of who the surgeon is. But I can tell you this is one condition, and when I watch Dr. Shelbourne do these surgeries where, you know, he's very, very good at this, and something I don't think I'm anywhere near as good at treating surgically as he is. But, you know, more importantly, the concepts that I've been able to learn over the years of working with Dr. Shelbourne about this specific complication after ACL surgery has been really great. And I feel like we have a unique perspective on this, and a setup in our office that really allows us to prevent this complication from happening and to also handle it when it pops up. A lot of this goes back to Dr. Shelbourne's work that he's done for the last 40 years, specifically our longer term studies that talk about what factors lead to long-term success and avoidance of functional problems, and also avoidance of arthritis in the long term. And Dr. Shelbourne and Tinker Gray, who was in Scott's position previously, have shown over and over and over again the importance of maintaining range of motion and how much worse you can make somebody if you allow them to get stiff after surgery. Of course, you know, when we do a surgery for instability, we're going to be focused on how do we stabilize the knee. However, what we found over time is that the stability, while it is of course important, is not as important as patients getting full range of motion back afterwards. And I think it's become pretty clear that if you have a knee that's relatively loose after a surgery, but you have full range of motion, you can still have a pretty good outcome. However, if you have perfect stability and your knee is rock solid stable and you lose range of motion in the long term, that's probably worse than the loose knee that you had to begin with. And so I think just right off the jump here, as we start talking about this, I think it's important, for listeners to go back and review Dr. Shelbourne's previous literature on factors that make a difference in the long term after ACL surgery, and review our previous content on this podcast that speak to that specifically, because that's really the foundation on which we really build avoiding this complication and treating it once it arises.
I like that you said prevention, and that's something that I really speak to when I talk about this topic with others, especially physical therapists. And the question is, well, if you are successfully preventing it, obviously you don't have this problem, but how do you prevent it? And that question typically comes up. It's like I said, especially in the rehab world. As far as the tips for preventing it, what's your thought on that? And talking to maybe a group of rehab professionals that are seeing these patients and hopefully before surgery, but is it as simple as get the motion back before surgery? And the second question would be, when you're seeing this after surgery, are you seeing the ones that you always see in case studies where you're seeing these patients that are 15 degrees short of zero and really a life-altering case, or is it sometimes just a 2 or 3 degree deficit that may be more symptomatic than you might think it is?
Well, I think from the very beginning, it's important to understand how debilitating this can be. And I think that it's also important to understand that strategies for dealing with arthrofibrosis are far inferior to strategies for preventing arthrofibrosis. And it's important for the surgeon, it's important for the patient, and it's important for the physical therapist. All three of those participants in the kind of care protocol for this patient understand that job of avoiding stiffness begins long before surgery. This is not a post-surgical complication. This is something that starts to happen from the very beginning when the patient first gets injured. I was at a meeting once at the Campbell Clinic at my where I did my training, and one of our former fellows, I was talking a little bit about stiffness after ACL surgery and arthrofibrosis, and he asked the question, well, so let's say that you've done everything that you can, and it happens anyway. We all have these patients that, you do everything right and they still develop stiffness. So what do you do? So I started talking a little bit about it. He's like, I know, but let's say you've done everything right and they've had a problem. Now what are you going to do about it? So I had to stop there for a minute. I said, okay, when I say we've done everything right and you say we've done everything right, I think we have to understand what those things are. To me, doing everything right means we do not do the surgery until the patient has full symmetric perfect extension to the opposite side. Until that happens, patient does not get a surgery almost under any circumstances. Or if they can't get their extension back, then sometimes we've even gone as far as to do a scope to take out the stump to treat meniscus tears that may be flipped over in the notch or whatever it is that's keeping the knee from getting all the way straight. It's that important that we would even go to the measure of doing a scope to improve the patient's extension pre-ACL reconstruction to make sure that we don't have surgery until they're all the way ready. And then secondly, we have to have them understand, their physical therapist and the patient understand, that keeping the extension perfect is going to be a priority throughout the entirety of the process. We need the surgeon to understand that when we do the surgery, we have to do it in a way that does not impinge the knee in full extension and keep it from getting full hyperextension symmetric to the opposite side back. So in the operating room, we have to make sure that we don't impinge upon the roof of the notch. We don't put the graft too anterior. We don't put too much graft material in there that it blocks extension in any way. And then we have to get the knee extension perfect the day of surgery, the day after surgery, 2 days after surgery, a week out of surgery, 2 weeks out of surgery, and forevermore going forward. We have to do that. So when we talk about what are all those things that we have to do, what's doing everything, those are the things that it goes into. And if you haven't done all of those things, if you skipped even one of those steps, then in my opinion, you're not doing everything to avoid arthrofibrosis. So that's an important thing to realize. The other one is, what's our goal with extension? I think people say, well, sometimes I hear people say, well, it's close and we'll get it over time and it'll come back over time. And unfortunately, the data doesn't bear that out. The data says that if you don't get it by the time you're discharged from initial physical therapy, whether that be 6 months or a year or whatever, however long it is, that it is not coming back, and that does increase your functional limitations, and it does make it more likely for you to get arthrofibrosis. I think it's also important to keep in mind what our goals are, in that our goal is the IKDC criteria is what we really use as our guide, as the goalposts on what we're trying to achieve. And IKDC criteria says that normal is full symmetric hyperextension, symmetric to the opposite side, with a with a 2 degree or less side to side difference. So if someone has 7 degrees of hyperextension on the uninvolved knee, and on the ACL reconstructed knee, they have 4 degrees of hyperextension, that patient, in our opinion, has arthrofibrosis. They are not getting full symmetric, perfect extension symmetric to the opposite side. And it's important to understand that even the minute differences can make a big difference in their outcome later on.
Now, one thing you talked about in there when you're talking about, kind of covering these incidence rates, if you will, getting into more of the causes, you mentioned some type of impingement. When you look at this postoperatively and you see these patients come in, what's your thought on as to the cause of this? Is it more of a graft tunnel mismatch and there is some type of physical impingement, or is there some type of overgrowth due to some healing potential of the graft? And that leads to a second question. Are you seeing these more with patellar tendon grafts, quad tendon grafts, hamstring grafts? And if you are, really, what's that reason, or what do you think the cause is for this condition?
Well, there's a lot of different factors at play. One of them is just understanding what our goals are, as I described them before, and the fact that everybody is educated on what makes the difference on patients getting their full extension back. If the patient doesn't understand that they have to get their knee perfectly straight before surgery, and they have to keep it that way throughout the whole process, if the therapist doesn't understand it, and especially if the surgeon doesn't understand, because a lot of us, in my opinion, probably don't understand the critical importance of full hyperextension symmetric to the opposite side. And even something as simple as, how do you measure range of motion? I got one time corrected at my fellowship because I was reporting hyperextension to the degree, and they said, why don't you just look at it in gradations by 5 degrees? So someone has hyperextension, say they have 5 degrees. I don't want to hear they have 1 or they have 4 or they have 7. And to me, that leads to it's an illustration of a misunderstanding how important every degree is, and that symmetry is really our goal. So those are pre-surgical and education factors. In surgery, we're big believers that the tibial tunnel has to be placed in a location where the knee, when put into full hyperextension, that the tibial tunnel stays posterior to the roof of the intercondylar notch. And you can see that on x-ray as Blumensatz's line, the roof of the intercondylar notch. So we like to see post-surgically that our tibial tunnel in full hyperextension is parallel and posterior to Blumensatz's line. That way we can have a radiographic way to show that we're not causing impingement. We also check that actively passively in the operating room. After we're done with surgery, we extend the knee into full hyperextension symmetric to the opposite side, and we watch that the graft fits perfectly in the intercondylar notch. And if it doesn't, then we take some bone away, do a notchplasty until it can allow full hyperextension. And then post-surgically, it's just about understanding what our goals are. And again, that the surgeon, the patient, and the physical therapist all understands that perfect extension is the ultimate goal. As it relates to graft types, we use patella tendons, and the reason is that we get early bone-to-bone healing, so we don't worry as much about fixation because the healing happens pretty early with patella tendon grafts. And with that, we don't restrict hyperextension at all in the early time after surgery. We tension the graft in a way that makes sure that you can get the graft into full hyperextension without putting too much tension on the graft. With hamstring grafts, I think there's some concerns with early healing and with early adequate fixation on with hamstring grafts. And because of that, a lot of times they will tell you to not go into full hyperextension early on after surgery for fear of stretching out the graft or losing fixation. And then there's some concern around quadriceps tendon grafts, at least in my opinion. I saw a study at a meeting last year where they talked about arthrofibrosis rates with quadriceps tendon grafts approaching 6 to 7%. And that of course is concerning, since we know that has long-term effects on function as well as development of arthritis down the road. So in my opinion, when you can go back to our previous episodes to hear why I think patella tendon grafts are the best graft, but in my opinion, those are the best grafts that we can use, and I think they have some specific advantages in that we can get good early fixation, no problems with impingement due to too much graft material, which could be a problem with quadriceps tendon grafts, and no early restrictions on full hyperextension due to fixation like we do have in hamstrings.
So knowing your thoughts on the causes of arthrofibrosis following surgery, what are some of the treatment options that you typically go with when you see these patients post-operatively?
Well, once you identify that a patient has any degree of extension loss, I think it's important to realize this is not a small problem. This is a big problem. In our office, it's a 5-alarm fire if somebody comes in a month after surgery and they're 3 degrees off on their extension. That's a big, big problem, and everybody in the office understands that can't happen. So just early recognition and proper appreciation of the gravity of that potential problem is a big barrier in the early time after surgery. When we get these patients further out, which is usually where we get them when we see them from elsewhere, by then usually the patient is a lot further out from surgery and has had more long-standing problems. And in that case, we're always starting with non-surgical treatment. It's important to try to control pain in whatever way you need to, or treat pain. We don't use narcotics usually, but an anti-inflammatory medicine or steroid dose pack, something to decrease pain and hopefully relieve some of that pressure in the front of the knee in order to get things under control, allow them to tolerate physical therapy. And another important thing early on is to recognize symptomatically the differences in posterior stretching pain versus anterior impingement type pain. Pain in the back of the knee with arthrofibrosis is usually related to hamstring and posterior capsular tightness, versus anterior pain and a feeling of impingement in full extension is usually due to the graft actually impinging the roof of the intercondylar notch and having too much soft tissue on the front of the graft, something like a cyclops lesion, for example, or fat pad fibrosis from the passage of instruments with arthroscopic technique that then adheres the fat pad to the soft tissues in front of the ACL. So it's important to know the difference between those. The posterior pain that happens with hamstring tightness and posterior capsular tightness usually will resolve or at least improve significantly with extension stretching, versus if the patient hurts anteriorly and feels pinching in the front of the knee when they fully extend the knee. Unfortunately, a lot of times you won't be able to smash that down enough in order to be able to get the patient out to full extension. So when a patient comes in with mostly posterior pain and stiffness, then I feel like the early time period is really focused on, can we get their pain under control, make them more comfortable, and then can we do some physical therapy for posterior capsular and hamstring stretching. Eventually, they may get to the point where they say the posterior tightness resolved as their extension improved, but now they've kind of plateaued where they're no longer getting improvements, and now they feel that anterior impingement type pain. That's where we think that we may need to intervene surgically when they have anterior pain limiting extension.
Now, going back to the acute phase, and you talked about the difference between when you or Dr. Shelbourne's operating on these patients and how we see them in our office versus seeing somebody that's more in the chronic stage and they say, I had surgery 6-8 months ago and I've been stiff since day one. You talked about it being a 5-alarm fire, and everybody needs to be on the same page to recognize the problem in order to properly treat the problem. When would you say that starts to be a concern to the point where maybe we need to get this patient in more often to really get on top of this knee extension deficit? And second question, but still dealing with the time frame, is when do you decide it's too late now, we need to start talking about either changing the course of treatment or we need to start looking at surgical interventions for the extension deficit? So what are those time frames for both of those examples?
I'd say by the 2-week visit, if they come in at 2 weeks and they don't have full extension symmetry to the opposite side, we're already thinking this is a big problem. And especially if we get out to the 1-month visit and the patient doesn't have full symmetric extension, now we're really starting to think this is an issue. And, those are some times where we will increase the frequency of therapy visits just to get them, lay eyes on them a little bit more and have the therapist working on them a little more hands-on fashion. As far as when it's too late and when we start to think about surgical intervention, I don't actually think there's a specific time frame in which I would say if it's not better by this time, then you got to move on. I think that's more about progression and less about specific criteria and time. That if a patient is, 4 months out from surgery and they have a 10-degree flexion contracture and they come in at 6 months and their flexion contracture has gone from 10 degrees to 4 degrees, I don't think that necessarily means we have to intervene as long as we've seen progression. So if their flexion contraction has gone from 12 degrees to 9 degrees to 6 degrees to 4 degrees to 2 degrees, then I think visit over visit, then I think we need to keep going versus if they have 15-degree extension loss and it goes from 15 to 12 and the next visit they're at 12 degrees loss and the next visit they're at 12 degrees loss and the next visit they're at 12 degrees loss. Eventually you have to figure out we're not progressing and things are in a bad place and they're not getting better.
One more question on this acute phase. I've had patients over the years where, and I think arthrofibrosis can feel different. If you have somebody, let's say in a subacute or even chronic phase where maybe they're only 5 degrees off, some patients come in and they're 5 degrees off and you put them in some extension devices. You really work diligently on maximizing their extension and you can get it. And then they come back and they're still 4 degrees off. You can get it on the table and at the end of the session, you say, yeah, I did a great job. They have full extension. They come back and they're stiff again. And you take that and you compare it and contrast it to somebody else who has a 5-degree extension loss. And some of those just come to a hard stop. And the infield of terminal extension, and let's call it terminal extension 5 degrees off. For the first person I talked about, I always describe it as kind of a spongy or springy feeling where you can get it there, but it just kind of pops back and forth versus that person that really comes to a hard stop. Is there a difference between those from a anatomy standpoint or a physiologic standpoint, or is that just person-to-person differences in how their infields are?
Yeah, I don't know that it's necessarily an anatomic or structural problem that's different. I just think that it's important to understand that those situations both happen. That if you say, this patient came in with a 6-degree flexion contracture and they're just not budging at all, then that's probably something we need to get an MRI scan, look for impingement, soft tissue in front of the graft, et cetera. Versus, I think sometimes if somebody has a 6-degree flexion contracture and you push them down and they can get to a 1-degree contracture, then the next time they come in 6 degrees, you can get them to 2. 6 degrees, you can get them to 2. 6 degrees, you can get them to 1. I think it's important to understand, even though those may seem like they're different from a progression standpoint, that the problem is likely the same. And really both those are just, a little bit different presentations of essentially the same entity. That something's up in the front of the knee that's keeping the knee from going all the way straight and staying there.
So take that same example we were just talking about, 5 or 6 degree flexion contracture. You start being concerned about it at 2-week point, at the 4-week point, you start making some more decisions. When does the imaging come into play? Is that something you're going to order around that time? And if so, what type of imaging are you getting on these patients?
From an imaging perspective, anytime somebody comes to see us with arthrofibrosis that's in surgery that's done elsewhere, we always get just standard x-rays, bilateral PA view, lateral views, and a merchant's view, just to get kind of a general screening type x-ray series that we give on pretty much all knee problems. But we also get an extension lateral view. We ask the patient to fully contract their quad, extend their knee as far as they can, and then we take a lateral view in that position. In that position, we want to see the tibial tunnel be parallel and posterior to Blumensatz's line. And if with the knee in full hyperextension, the tibial tunnel is anterior to that line, then that probably is telling us that the ACL graft is impinging on the roof of the intercondylar notch in full extension, and that's probably blocking things from moving forward. If we don't see that on regular x-ray, then we have to move on to some advanced imaging, and MRI scans really the best that we have there, looking for a cyclops lesion, some soft tissue in front of the main portion of the ACL graft that when the knee's fully extended is going to impinge upon the roof of the intercondylar notch. The other thing that we've seen a lot of is a lot of fat pad scarring and just thick cords of scarring going from the fat pad all the way into the anterior portion of the ACL graft. And this can really tether the fat pad, and because of that cause range of motion loss by that fat pad really getting stuck down. And in our opinion, the arthroscopic technique is worse for this than open technique. I know people think open technique is old school and archaic and things like that, but by opening up the knee to do the ACL surgery and sewing it back together pretty gently, I think we are able to avoid a lot of that fat pad scarring versus, when you do arthroscopic technique, a lot of times you're passing sharp instruments back and and forth repeatedly through those arthroscopic portals, and we can really see some pretty profound scarring of the fat pad into the front of the intercondylar notch, into the front of the ACL. So we usually start with plain X-rays and then moving on to MRI scan as needed to look for any kind of impinging soft tissues up in the front of the knee.
So now when you have these patients, you get the imaging done and you decide that a surgical intervention is going to be the best course of action for this particular patient. What's your surgical plan and what are you seeing intraoperatively and how does that go?
So surgically, there's a question in the literature, if you read about this, on whether this is an anterior problem or a posterior problem or both. And, I think it was Dick Stedman in the past that's talked about anterior interval release, trying to release that anterior scarring to the front of the ACL graft and trying to free things up that way. And then I've read other things about people making posterior portals, removing scar from the posterior compartment, maybe even releasing the hamstrings in severe cases, things like that. In our hands, that has not been necessary. We believe this is an all anterior problem, that the posterior problems will stretch out with physical therapy versus the anterior impingement and the mechanical block that we have to the knee getting into full extension is not something that will get better with physical therapy. So if we've had the patient make initial progress and then eventually develops anterior pain that's not getting better, then we go on to an MRI scan, we find some scarring in the front of the knee, and we choose to go ahead with surgery. Couple technical pearls on this. We usually make our portals a little bit wider. The scar can be a little bit further, not just in front of the intercondylar notch, but also from the anterior horn of the medial and lateral menisci where the anterior horns insert. It can really spread that entire anterior portion of the knee. So we'll kind of get down on, and once we've made those portals, a medial and a lateral portal that are wider than average, then we'll try to get to the front of one meniscus. And I guess it doesn't really matter either side, but either one. Get on the front of the meniscus and get into the scar tissue and take that down all the way to the attachment of the anterior horn of the meniscus and find the tibia in the front. I think that's an important thing to do, is get through that soft tissue all the way down onto the tibia at the level of either the anterior attachment of the medial or the lateral meniscus. And then once you do that, then you kind of start to work your way along the tibia over to the opposite side until you reach the anterior horn of the other meniscus. And that kind of develops a plane between the back of the fat pad and the tibia and the soft tissues that are on the front of the ACL. And then once we do that, then we start staying along the tibia and moving further posterior until we get to the anterior portion of the ACL graft. This is where it gets, for me, it gets really difficult and pretty nervy, is when then you have to come kind of, once you get underneath all the way up to the front of the ACL graft, now you can't keep going any further posteriorly or you'll be getting into your ACL graft. So now you have to get up on top of the ACL with a bunch of soft tissue stuck to the front of it. And we use an Arthrocare wand for this as opposed to a shaver, just because it allows us to develop those planes a little more cleanly and it doesn't generate as much debris, things like that. So that's when we start to take that Arthrocare wand and start going through soft tissue on the front of the ACL until you start to see ACL fibers, and then you got to stop. And that's where I get nervous. And I've seen Shelbourne do this a lot, and he's peeling away and he's going away at this soft tissue in the front of the ACL, and I'm in the back watching, biting my fingernails because I'm worried that we're going to get into the ACL graft. But once you find the front of the ACL graft, then you're starting to peel that stuff away from the front of the ACL until you get down to the tibia. So now you develop those medial and lateral planes, you take it all the way across the front and separate it from the fat pad, and then you get in front of the ACL, take that all the way down to tibia, and then you kind of isolated this soft tissue in the front of the knee. And then you can either take the Arthrocare wand in smaller lesions and just kind of burn through all that all the way down to the tibia as it all kind of evaporates and goes away. Or you can actually try to remove it in mass as, almost like a loose body removal, and remove it from the front of the ACL. That's the soft tissue portion. So once you've done that, hopefully before you started, you extended the knee fully to see where the ACL and the soft tissue on the front of the ACL impinges upon the intercondylar notch, and that you get all that soft tissue away. And then you extend the knee again to see if the ACL is fitting up into the roof of the intercondylar notch. Sometimes you do even have to peel a few fibers of the anterior portion of the ACL away. Now, does that put your ACL graft at risk? Of course it does. However, if the ACL graft is impinging resulting in full extension. As we've talked about before, having an ACL graft that impinges in extension resulting in extension loss is a bad long-term prognosis. So if that's what it takes to take even just a little bit of the anterior fibers of the ACL, then I think that's something that probably needs to be done. The next thing you have to do is to assess whether or not there's any bony impingement from the intercondylar notch. So a lot of times you can actually see a color change between the edge of the native intercondylar notch, where it's kind of glistening white cartilage, and then the osteophytes or kind of bony overgrowth that will be kind of overhanging the wall of the intercondylar notch. Sometimes it'll be a little pinkish like an osteophyte, and sometimes you do have to do some bony work as well. Some people use a burr for this. We like to use a small osteotome. You just really can get a sharp edge, and so you're not buzzing away, cell layer by cell layer, just trimming away a little bit bone at a time. You can put that osteotome, just a skinny one, through an arthroscopic portal, get right on the edge of the bone that you want to take off, give it a little bit of a tap, move down a little bit, give it a little bit of a tap, and remove it as one big piece rather than shaving away a little bit at a time. And then again, reassessing as you take more and more bone away until the ACL graft fits perfectly into the intercondylar notch with the knee into full hyperextension. And the another thing is, you got to realize this is not a short surgery. I watched Dr. Shelbourne do, medial meniscectomies, and the tourniquet times, 14 minutes. It's pretty fast, or sometimes even less. With arthrofibrosis cases, sometimes, even though it's a knee scope, there can be tourniquet times reaching 45 minutes, 60 minutes, 70 minutes of meticulously getting this soft tissue out of the front of the knee, off the front of the ACL graft, removing it completely from anterior horn of one meniscus to the other, and then also going away and removing some bone until you do not leave the operating room until you have the knee into full hyperextension without impingement in the front of the knee.
Well, as you had mentioned, this is something that especially Dr. Shelbourne has seen for a long time now, and seen a high volume of them. And at one point, he decided to classify these patients into certain categories. So can you touch on that a little bit in terms of how you classify these patients postoperatively?
A quick word about classification systems. I think one of the everybody wants to have their name on a classification system of whatever that is, whether it's the Schatzer classification or the Logie-Hansen classification for ankle fractures, et cetera. We have all these classification systems, but it's important to keep in mind what these classification systems can really do. They can really facilitate communication, is a big part of it, and they can also help to guide research into these topics and give us a way of separating them as we study them. And then also, hopefully, if you have a good classification system, it can guide your ultimate treatment patterns. And we kind of touched on this in you mentioned earlier, a research study that we are going to be presenting at the AOSSM annual meeting in Denver this summer. So let's just get right into that. This study is called Results Following Arthroscopic Scar Resection for Arthrofibrosis Post-Anterior Cruciate Ligament Reconstruction. And the lead author on that is Bill Claussen, one of the therapists from our office. Scott Bauman, who's on the podcast with me here, is an author on that as well as Dr. Don Shelbourne and myself. So Scott, kind of lead into, I guess we've already done a lot of introduction on this. So tell us a little bit about the classification system and how that leads into the methods of this study.
Yeah, as you mentioned, we kind of hit the background already, and the purpose was to just do that, was to define certain categories and see about a classification system for these patients after surgery. And then second step of this study was to take that classification system and then look at their postoperative outcomes as it pertains to range of motion and subjective scoring. So what we did was we ended up with 166 patients that we've seen postoperatively after ACL reconstruction that had a scar resection, and we did exclude patients that had an ACL on the other side just to keep things equal when it comes to range of motion. And we put them into 4 categories, and we based these categories off of the range of motion that they have after their ACL reconstruction and prior to their scar resection. So category 1 was those with minimal range of motion loss, all the way to category 4, which is your more severe cases with pretty extensive range of motion loss. So category 1 were patients that had an extension deficit of less than or equal to 10 degrees, as well as a flexion deficit less than or equal to 5 degrees. So pretty minimal on both of those scales. And then it goes more severe from there. So grade category 2 is less than or equal to 10 degrees of extension, just like the first category. The difference is these patients have a more than 5-degree flexion deficit. And then category 3 jumps up with the extension deficit as those that are more than 10 degrees off on their extension, and then a minimal flexion deficit of less than or equal to 25. And then category 4 is going to be the more severe cases, and those patients have greater than 10-degree extension deficits as well as greater than 25 degrees flexion deficits. And keep in mind with these categories, they are deficits compared to the other side. As you mentioned, Dr. Benner, earlier, that you got to have a goal for these patients, and the goal, not only in the operating room, preoperatively and postoperatively, the goal is to have their extension and their flexion equal to the other side. And if it's 7 degrees on the non-involved side, we want these patients being 7 degrees on the involved side postoperatively. So that is how we categorize these patients. And to round out the methodology for this study, from an outcome standpoint, we want to look at their preoperative and postoperative difference in range of motion and see how that compared between these categories and what their progressions were, as well as having the rate of quote unquote normal range of motion. And again, at our office, we consider normal to be within the IKDC objective form criteria of 2 degrees or less from an extension deficit standpoint. And then the last outcome we wanted to look at was the IKDC scores and see if there were any differences across these categories.
Yeah, that classification system I think is really a good one in trying to separate. Is this an extension only problem? Is this a flexion only problem? Is it a flexion and extension problem? And is it a more severe flexion and extension problem? It takes into account not only severity of range of motion loss, but whether it's in extension or flexion or both. So again, a classification that helps to facilitate communication and eventually hopefully guide treatment. Tell us about the results of this study. What did we find?
So first and foremost, we want to look at the frequency distribution of patients that were normal preoperatively as well as being normal postoperatively. And this shows pretty drastic differences here. For the category 1s, again, these are those patients that have pretty minimal range of motion loss. We had 82% of these patients preoperatively to have normal extension, and then postoperatively, they were able to improve upon that to be 97% of those patients had normal extension. For category 2, only 48% of patients had normal extension compared to 95% after surgery. And then categories 3 and 4, none of them had normal extension because their category really graduated them out of that level. But then 100% of these patients in groups 3 and 4 were able to have normal extension after surgery. On the extension note, another pretty interesting finding, and one thing that we really strived to find out with this study was, are there differences in postoperative extension deficits depending on what your preoperative motion looks like? And this is really what drove some of the clinical questions before this study started was, going back to that example we were talking about and when we were covering the background here, is a patient that has a pretty severe case. They have, let's call it a 15-degree flexion contracture. They're really struggling. This is a pretty life-altering condition for them versus somebody that may only have a 2 or 3 degree flexion contraction, and they're more of that spongy type that's just springing back and forth, but it's enough of a deficit to cause them to have some symptoms to the point where they're going to pursue this scar resection. So you have a scar resection surgery for patients that are seemingly in 2 different buckets here, and as a category 1 with minimal range of motion loss preoperatively compared to the more severe case in a category 4. So we really strive to see, is there a difference postoperatively between these cases in a sense between these categories? And we found from an extension deficit standpoint, there really was not. So the difference in postoperative extension was not different based on your preoperative category, with all 4 categories having a mean or an average of 0 degrees from an extension standpoint, meaning that no matter what your deficit was preoperatively, postoperatively following your scar resection, the average was a 0 degree extension loss, which I think is pretty tremendous and something that was, in our opinion, a pretty remarkable finding considering some of the cases we've seen.
Tell us about the subjective scores as well. This is where this data gets even more interesting, in my opinion.
Yeah, I would agree. When we look at the preoperative scores for the IKDC, which is the measure that we collected on these patients, the IKDCs were statistically significantly different preoperatively, with the worst scores being towards the more severe cases or the higher categories. For example, preoperatively on the IKDC, category 1 had an average of 63 compared to 45 for category 2, 16 for category 3, and 32 for category 4. So you look at those categories 3s and 4s, which per our classification system was greater than 10-degree extension deficit, prior to their scar section, these patients are really struggling. And not to say that the 45s and the 63s for the categories 1s and 2 are not struggling either, because I really think they are. But like I said, with these more extreme cases, it can be pretty life altering. And a score of 16 and 32. These patients are usually young and healthy patients having an ACL reconstruction, and then their mobility really takes a big hit when they have an extension deficit of more than 10 degrees, which is evident as per their low IKDC score preoperatively. And then postoperatively, there was not a statistically significant difference between the postoperative IKDC scores across the 4 groups, with category 1 having an average score of 81, category 2 also 81, category 3 83, and category 4 100. So when you look at the change over time from preoperative to postoperative in terms of pre-scar resection and post-scar resection, there's some pretty drastic and pretty, again, talking about life altering, pretty difference or pretty big increases in the IKDC scores. And again, another interesting note from a statistical standpoint is there is not a statistically significant difference in postoperative scores after surgery, similar to that of the extension deficit. So no matter what category you're in preoperatively before your scar resection, postoperatively, you're going to be doing the same across the 4 classifications when it comes to extension deficit as well as IKDC scores.
Yeah, I mean, it's really remarkable how bad some of these people are. And I think the point that you made about the fact that these are mostly young, healthy people is really an important one. Young, healthy people should have IKDC scores at or very near 100. And we're talking about some of these people that, maybe 18, 19 years old that are reporting knee function scores that are in the teens or in the 30s versus, where they should be 100. So really, really significant reductions in their overall functional capacity. And then post-surgery, the interesting thing is no difference in their post-surgical scores, regardless of which group they were in. So, whether they had relatively mild degrees of range of motion loss or more severe degrees of range of motion loss, they still got better and got to about the same level. The thing that's important to realize, and this goes back to that for prevention piece, is that these people get back to IKDC scores hovering in the low 80s. The type 1s and 2s averaged about 81 on the IKDC. The type 3s are 83, and the type 4s, even though we have an average IKDC score of 100, that's a pretty small group. So in general, the patients end up with about a low 80s IKDC score. And while that's much better than it was pre-arthroscopy for arthrofibrosis, it's still not as good as these patients would have gotten if they had just a primary ACL reconstruction and did well. In that case, they're more like the mid to high 80s, sometimes even into the 90s. So unfortunately, a lot of times we have to counsel these patients. We can make you better, but we can't necessarily make you as good as we would have had we not had this complication in the first place. So I still think that's an important piece of things to realize, that the prevention, an ounce of prevention is worth a pound of cure when it comes to this problem. That even if we have a good outcome, it would have been better if we can just prevent this problem from the beginning.
So as we start to wrap up here, Dr. Benner, do you have any final thoughts or take-home messages for any of the clinicians listening, whether it be orthopedic surgeons or physical therapists, when it comes to arthroscopic management for arthrofibrosis after surgery?
Yeah, absolutely. The first one is that just remembering what our goals are. Our goal is absolutely perfect extension symmetric to the opposite side, including hyperextension. And the uninvolved knee tells us what our goals are when it comes to extension. Secondly, we have to get that before surgery. We have to get it during the surgery. We have to get it early after the surgery and late after the surgery. We can't ever allow extension range of motion loss to really creep in. And we definitely can't let it get out of hand in the early time after surgery. The next part is, if you're seeing these patients in the post-surgical phase and they've had this complication, recognizing the difference between posterior stretching pain and anterior impingement pain is a really important one. Do the physical therapy up until you feel like the posterior pain's resolved and the anterior impingement becomes the issue. If that never happens and you get them all the way back to full range of motion, then great. But if you eventually start to have anterior impingement pain and no progression with the extension, you think that they have a mechanical block, get an MRI scan, look and see where that scar tissue is located dislocated. And then if you end up progressing onto surgery, this is an anterior problem. Make sure that you do both the soft tissue and the bony work to free up the ACL graft to be able to fit perfectly in the intercondylar notch. And then from a results standpoint, that unfortunately is as good as we can make these patients compared to where they were before. You can never really make them as good as you could had you avoided this complication from the very beginning. So always trying to get this thing right from the very beginning.
Excellent. Well, I appreciate you taking the time tonight to go over some of the details of this condition, from the incidence to the causes all the way through. What I thought was really some of the most important aspects of tonight's episode was the surgical details and what that looked like. So I appreciate you going over that as well as the study. So if you want to get in contact with us, we are on all the social media platforms, on Twitter and Instagram at the SKC Podcast. You can visit the SKC Podcast YouTube or Facebook pages, or you can email us at the skcpodcast@gmail.com, and we will see you guys next week.